Mallory-Weiss Tear. A Mallory-Weiss tear is a longitudinal mucosal laceration at the gastroesophageal junction, typically caused by a sudden increase in intra-abdominal pressure. It is a recognized cause of upper gastrointestinal bleeding and often occurs following forceful vomiting, retching, or coughing. Peak incidence. It most commonly affects adults between the ages of 50 and 60. Pathophysiology. A sudden increase in intra-abdominal pressure during events such as vomiting or retching causes a mucosal tear at the gastroesophageal junction. The tear is usually confined to the mucosa and submucosa. It may lead to bleeding from submucosal vessels. Symptoms: hematemesis, vomiting of fresh red blood or coffee ground vomitus. Melena, black tarry stools due to digested blood. Epigastric or upper abdominal pain. This may occur before or during bleeding episodes. Dizziness or syncope, due to volume depletion in more severe cases. Signs. Signs of shock may be present if bleeding is significant. Hypotension, tachycardia, cold peripheries, and pallor. Diagnosis. Clinical suspicion should be raised in patients presenting with upper GI bleed and a history of severe vomiting, retching, and excessive alcohol intake. Esophagogastroduodenoscopy, OGD, is the gold standard for diagnosis. It visualizes the longitudinal mucosal tear at the gastroesophageal junction, and also helps exclude other causes such as varices or peptic ulcers. Angiography. This may be considered if bleeding is ongoing and endoscopy is unsuccessful, can also serve as a therapeutic purpose via embolization. Complications. Complications of Mallory-Weiss tear include recurrent bleeding, hypovolemic shock, and rarely progression to full thickness esophageal rupture, i.e. Borhave syndrome. Management. Initial management, ABCDE approach. Hemodynamic stabilization. Administer IV fluids and blood transfusions if needed. Pharmacological support. Antiemetics, for example ondansetron, to prevent further vomiting. Proton pump inhibitors, PPIs, for example omeprazole or esomeprazole, to promote mucosal healing. Reversal of anticoagulation if the patient is on warfarin or DOACs. Definitive management. Endoscopic therapy, first line. Adrenaline injection to induce vasoconstriction and control the bleeding. Thermal coagulation, for example electrocoagulation. Band ligation may be used in more severe cases. Angiographic embolization. This is reserved for patients with ongoing bleeding where endoscopic therapy fails. Surgical intervention. This is very rarely required and is considered only when both endoscopy and angiography are unsuccessful. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today